one thing before we go to the next thing. There was a question about the tibial rotation. If you see the functioning of the knee, the tibial rotation, mainly it will work for the patellofemoral joint. Right? If your tibial rotation is right, your patellofemoral tracking will be right. Your patellofemoral joint is working on a ligamentum patelli and PCL axis. So if you take the medial third of the tibial tuberosity and the center of the PCL, what we do normally in robotics and even in navigation, just draw a line and you put your tibia on that and cover the lateral condyle fully. In 90% of the time, that will give you the correct native rotation of the patient itself, and you will have no problem as far as tracking is concerned. I follow that, and I believe that that's the best way to do it.
So that's a repetition of what Dr. Rajput just mentioned, and I think it's important that all of you register that.
Problem
So my question was,
robot is still not helping us with tibial rotation. That's one drawback of robot, I think.
Yes.
Still not helping us with tibial rotation.
so my question was,
डॉक्टर नहीं लग रहा कभी नहीं लगा
so my question is, how many of you are using pie crusting to balance your gaps? Can I have a show of hands? So a
Yeah,
good number.
I just want to ask you
May I
something. Are you
ask-
talking about pie crusting of MCL or PCL?
MCL.
MCL, okay.
Yes. So my question to the panel is, sir, what is your take on pie crusting of MCL, or what is your technique if you use it?
It's one of the absolutely last thing I do. In robotics, I have never had to do. We've crossed 500 robotic TKRs and I've never had to do pie crusting. In conventional techniques, of course, I have actually got better at a lot of other things which we are doing now. It's very low. If I have to do, I normally take one, I do needle, I don't do knife. I do needle and I see where you are tight. You're tight in flexion or you're tight in extension. So that's you are going to know. And where you are tight in that position, you have to do the pie crusting. So quite commonly, it's the flexion gap which we are not getting in. So you do it in flexion pie crusting. You go to the fibers which you feel are tight. You feel them and then you do. So maybe a stab of about 6 needles, again test. And it's a very limited pie crusting. You can't keep on pie crusting. You remember, lateral side you have lots of structures. Medial you have only one, like a gamma pal one, only MCL. So don't bugger it up. That's my only thing.
Sir, excuse me, sir. Sorry, sir. What is your take on mediolateral mismatch after cutting the femur?
So-
Mediolateral mismatch.
So yeah, I mean, I got your question, sir. Let me just close pie crusting for everybody. So pie crusting should be done with caution, and most of the experienced surgeons are not doing it unless it is the last thing, nothing else is working for you. And never do pie crusting in flexion. You do it with a laminar spreader and do it in extension, and use only needle and poke it in limited number of times. So sir is waiting for the lecture, but let me just take that question. He's asking if there is a mediolateral mismatch of the components.
So let me tell you, this is
are
a
you
whole
bothered by
debate
that?
actually here. Sorry, is anybody answering? So there's a whole debate about mediolateral mismatch because we don't know what is the right balance. If you ask 10 surgeons, you will get 10 different answers. What exactly is a balanced knee? So if you look at normal knees, we have, let's say medial side 1 laxity, lateral side in extension 1 laxity, 1 mm, lateral side 1 to 2 mm laxity. In flexion, we have 1 to 2 mm medially and up to 4 or even 5 mm laxity laterally. Now if that is being replicated in the TKR you are doing, is that a good thing or not? Is a question for debate. But if you're a mechanical axis going person, at this stage you need to try and match your gaps.
No, sir. Actually,
Your question is about
my question is cut.
mismatch on the bones.
Yes, sir.
Correct.
Implant and cut.
So he's asking, let me rephrase your question. He's asking, I have sized my femur in AP, but there is a mediolateral mismatch. Sometimes there's an overhang, sometimes there's an underhang. How do you tackle with that? Is it bothersome?
Just forget it, lateralize your component to some extent as much as you can because your patellofemoral tracking is matter. This is something what we call as an aspect ratio. Most of these implants were designed by the Western countries where the aspect ratio is different. If you look at the study from IIT Powai, our aspect ratio is different. And that is why we have more of this problem of mismatch anteroposteriorly and mediolateral. So read aspect ratio, look at the paper from IIT Powai, you'll understand why we are in trouble. That's why the anthem from Smith Nephew was launched based on the aspect ratio of Asian population.
Thank you, sir.
And few systems have narrow femur as well, like Attune. So you can, if you have that system on.
And again, never try to overhang the femur. Absolutely. You can undersize, but don't try to overhang the femur. Can I start? So,
We are looking forward to your talk. Please.
thank you, Dr. Valajan. Friends, I'll just compliment what Dr. Maheshwari talked, what Dr. Rakesh Rajput talked. So they have shown you the technique of doing a good knee. I'll just give you some points and some thought-provoking points I intend to tell you. And that should be interesting, I hope. Oh, it doesn't, okay. So this is a right knee and left knee. The right knee was done in 1997 and the left knee was done in 2001. The right knee was a cruciate retaining and the right knee was done when I was doing 8 to 10 knees in a year. The left one was done when I had crossed doing 50 knees in a year, and that time I was doing both. There is a cruciate substituting knee, and also I was doing LCS knee. So I started my career with a cruciate retaining surgeon. In 2001, I shifted both the sides. From 2002 onwards, I am doing primarily cruciate substituting surgery. So that's a reverse thing which is happening with me, and I don't regret it. I'm very happy. So the things what I mean to say, this joint lasted. Unfortunately, I lost this patient last year only, after staying for 25 years. And if you see the joint, the left knee and right knee, sorry. The left is a FS knee, Freeman's FS knee. There's one surgeon who has worked with the surgeon, but few people must have seen this. It was a 3 pegs in the tibia, and I was trained in Germany where I was trained not to take cement inside the bone and just apply a thin layer of cement over the bone. And this implant could have been used without the, especially femoral component, without cement, because it had pegs also. And I was using patella button all the time since 2001. In 2001, I changed. But it lasted very well. And this lady was rheumatoid. If you look at the bone, still osteoporosis was there. And you look at, because again, you can appreciate. Look at the proximal to the knee joint on the left side. Because that was done with a classical approach where I used to strip a lot of tissue proximal to the knee joint. And still it lasted. It led to a lot of calcification there. So the range of movement was not very high the way now we have. But yes, it was more than 100 degrees of flexion and she was very comfortable. This patient is still living, so I'm just quoting you. This was done in 1998. And you can appreciate the varus cut in the tibia. It was not done intentionally. When I saw the X-ray, I was aghast. I was shattered. VIB patient. And that time also I was doing hardly 10, 12, maybe. Because in 2000, I first time reached 48 knees in a year. So that was a landmark for me, I remember. So that was done when I was doing maybe 15 knees in a year. It was gradually picking up. So it was a cut in varus, not intentionally, unintentionally, a little obese patient. And I thought I'm gone. Anyway, she was doing very well. And then and this again a Apollo knee, a cruciate retaining knee. And then I did the other one, which was a PFC Sigma. And that was done in 2002. But what has happened? This is the lateral view, and you can appreciate the way she is walking. She has now a she has been operated for spondylolisthesis in the spine. Still, she is a big advocate. She was going up 4 stories up and down by stairs because the local court doesn't have a lift there. But she has survived all the years. So how come a knee cut in the varus has survived so well in a little obese person? Having a spine problem because of the waddling there, whatever. These are the thoughts to ponder. We have talked about a lot about robotics, the alignment and everything. So what are the critical things which will lead to a longevity and a satisfied patient? These are all the things which we must try to see. Another thing, most of our patients will sit cross-legged. You cannot stop them. If they can, they will do. You don't forbid them. So the time has come, friends, when we have to accept it. We have to make them sit comfortably cross-legged. You can tell them, but they will sit cross-legged anyway. So still, if you look at the literature, 15 to 20% knee patients are unhappy, and we'll be talking about that. Dr. Rajkumar has got a lecture on that. But patients are now demanding also. They want to lead a normal life. They don't want to say, well, I have got joint replacement, so I'm inferior. And even we don't want. We also want them to lead a normal, fulfilling life in all the aspects. So there have been so many advances over the years. I'm talking about 90. I started doing joints in 90. And that's why I said when in 94, 300 knee joints were done in the country. One was mine done in Cawnpore. So yes, the patients are there. They are evolving. So are we evolving. We got a mobile bearing with high flex just to facilitate high flexion, but we got to know later on, no, it doesn't make any difference. The fixed bearing can also work same way, and we have seen that. So what we have now, various materials which are changing, polished chrome cobalt tibial plate, newer poly, I think they are very remarkably changing our outcome, and various coatings, oxynium, titanium, nitride, the gold knee which we call for marketing purposes. I'm sorry for the marketing purpose word. And devices. To get the knees right, the computer navigation, patient-specific jigs and implants, and robotic arm. We had a lot discussion. So these are the devices. Whatever concepts we try to execute, these devices will help you in doing that. You want to do a kinematic knee, you want to balance. These devices give us a lot of information before surgery, per operative, and whatever we execute, every execution steps, these devices give a lot of information. Definitely I do not use robotic arm, but I use computer navigation, but I use my hand, my devices, I use caliper. Even if with the help of computer navigation, I will cut a bone, I will measure it. I want to know what I'm cutting. If I desired 7 millimeter, did I cut 7 millimeter or did I cut 8 millimeter or did I cut 6 millimeter, 5 millimeter? The information is the key to successful execution. So every step of execution should be verified when you are doing a surgery. And Dr. Jiten Mashri showed you how small things can make a lot of difference. Leaving a small amount of bone on the lateral condyle of tibia can lead to a varus knee unknowingly. So don't do that. So this is one of the papers which opened the eyes of many. And this is coming from Mayo Clinic. There are many now, but I'll just quoting this, which shows that a post-operative mechanical axis of plus minus 3. So on this outlier, even beyond that, it did not affect the survivorship of the joint. So a patient who are outlier, they are beyond plus minus 3, they survive better than the people who were absolutely in the strict in the range of strict alignment. So this is very important. This again opens a lot of eyes and we start thinking, what is there? What is the critical thing? And then we have got so many other things, like the joints also kept on evolving, the posterior cruciate retaining, and there were two philosophies which we started with. Then kinematic principle came because we appreciated the natural varus is there, how to create a gap based on varus, and definitely The mechanical joint is a mechanical joint. Kinematic is trying to restore the anatomical joint, which we know that our joints are inherently invariant, but again it varies from person to person. Like Caucasians are different. African race have got more valgoid knee. So you cannot have a uniform policy. And here also, when you see your patient, every patient is different. So how to go and evaluate that? If the other knee is good, take another X-ray. But most of the time it is not so. What I do, I would have, so based on this, try to go individualize it. And definitely robotic arm will help because it gives you a lot of information. The varying radii femoral component have come, the fixed radius has come, a gradius femoral component which now I use has come. Medial pivot design has come and has shown very good promising result in the short-term follow-up. Bicruciate retaining definitely has been taking care. Now it's coming in big way. We do not know. Long-term results are not known. So what is the aim? The aim is to stabilize the joint in whole arc of movement. This is the, I think, very important thing. So all this evolution in the joint surface, the joint alignment, the radius, is basically done to stabilize the joint in the whole arc of movement. So in my opinion, and not only mine, if you look at the literature, the two things which are very important for a successful and happy patient is balancing the whole range of movement. That's one. Number two, restoration of the joint line. And that's very vital. I'll just give you an example. We cut 9 millimeter of distal femur. Why we cut? We cut because the thickness of the femoral component is 9 millimeter. Suppose both the condyles are eroded and you cut 9 millimeter of that and restore with the 9 millimeter. So you are restoring the joint line to the eroded surface. So that's not restoring the joint. So the people who do unicompartmental, they know how we restore the joint line, we restore the actually surface. We take into consideration how much cartilage has been lost. So we cut less, restore or replace with more. So that is very important. You have to know, see the anatomy. The valgus angle, you look at the hip. Dr. Maheshwari said, my valgus angle will vary. Definitely it will vary. Because in a coxa vara, you cannot have a 5 degree of distal valgus. You will have to have 7 degrees of valgus, maybe 8 degrees of valgus. Definitely computer navigation will help us. Otherwise also we have got our eyes, we have got a straight line, take a scale, try to visualize where the valgus angle should be. So these two things are very important for a good functioning joint. Again, mid flexion stability. Dr. Simon Thomas just said how it was, his robotic arm evaluation said it's not stable in mid flexion. And we have got papers which show that mid flexion instability can be a major cause of unhappy patient also. So we started with the unhappy patient as a cause with the patella button. The patella, it's the anterior knee pain. But no, friends, there's so many more things which are happening there. So this is what Attune said, and that's why I like Attune. Yes, I have got good experience. I started in 2010, and since I think 2016, 15, I'm using primarily all my knees Attune because it has got a good curve or stabilizing well. I'll just show how. That's my biases for the Attune knee, and all the knees will fail. Why they will fail? This is one of the patients I was talking about where I did a primary knee. This is the infected knee. Was kept on, once it was revised, was done same debridement and the insert was changed and whole debridement was done. Not done by me, done by but very good friend of mine from western part of India. Was kept on antibiotics and anti-tubercular treatment for 2 years. And after that, it took a call, I have to revise it. I was mentally prepared to do 2 stages. I did definitely all the parameters. I did a CRP, I did the aspiration, all came negative. In tuberculosis, it can be negative. And I did a frozen section also. So I did a stage 1. So knees will fail. and infection can be a very important cause for that. This is what I did, and this, you can see the inserts. This was what done, and this is what I did. Another one, it failed. Why did it fail? It failed because of little adventurism is doing a primary knee. So, very small size, and the whole medial condyle was necrosed there. I did not use a stem because two surface or two zone fixation is good enough. So I did that. So I would like to tell you, all the knees, good or bad, can fail. But if I have to tell you, most of the knees in this era where I showed you the joint FS knee lasting for 25 years, an Apollo knee lasting for 26 years, the joints will fail only by infection medullary or surgical adventurism. So friends, surgical adventurism should be as minimum as possible, and meetings like this, interaction with senior colleagues will help you not doing any adventurism during surgery. So most of the knee now should perform well, should last well. That is the whole motto. Don't think you are doing it for 5 years, 10 years. Yes, it should last lifelong of the patient. That is the aim. Just one I want to show, looking like very grotesque deformity. Again, Dr. Maheshwari, for you, this is what he said. Looks very grotesque, not correctable. But not correctable, why? Because there's so much of osteophytes there. So much of osteophytes. Look at the posterior side, so much of osteophytes. So it is not correctable, but we have to create a gap and balance it well. So how we do it? Yes, this is what I did, both in two knees. And we cleared the whole posterior space. That is very, very vital. If you look at the posterior, there's so much of osteophytes. I've cleared all these spaces. And that is, again, a very important thing for getting a good function. We saw in the first case, the posterior osteophyte. You do not try to leave any posterior osteophyte. They are a cause of pain. They are a cause of limitation in flexion. So try to release. I don't release anything, frankly, mostly. More than 95% of the cases, or maybe more. I do all the cuts, measure all the cuts, go to the trial stage, and then I see what is there. If there's anything, I will manage that. But if I'm doing all according to my plan, why anything should go wrong? And this, I'm sorry because I made the lady walk without support. She was never walking without support. This is a tight knee, the only thing. And look at after 4 weeks. Now again, very important. So how I decide my successful knee? Based on, I said, I will do everything to keep on verifying all these steps, whether by computer navigation or with my caliper, my SS, my rods. I've got a pen, I've got a rod, I will put up a rod. I have got always, even if I'm using a computer navigation, I have put up a mark at the femoral head, center of femoral head. If necessary, I'll put up a rod and see that how my alignment is going. Every tibial cut, I keep a tray and a rod and see that it is 90 degrees. Yeah, I know to assess the tibial 90 degrees is very good. 90 degrees your eyes and brain always perceive. They will not perceive 10 degrees, 5 degrees, 2 degrees. But 90 degrees your brain will see, your eyes will see. But still I will always verify all my cuts, whether I use computer navigation. So my idea of balancing is this. When I flex it and I see there's a little opening on the anterior side of the knee, that means when I flex it, it is going a little tight. So what I will do, I'll see in all the range, all the time, and see mediolateral stability in whole arc of movement. And if it is tight, it is opening little anteriorly, that means the 3-degree slope is not right for this patient. And I'll increase the slope little bit so that my joint sits first. So I will not accept anything till I get this. So we try to see in full extension, we see in full flexion and we rock the knee all the time. And the most important thing, the patella should be absolutely in the center all the time. It should be snugly floating over the femoral condyle, no tilting, nothing. And the joint should not move. My trials will not move in a couple of millimeters when I do a flexion, full flexion and full extension. If I have achieved this, I know the patient will be happy. So this is very important from my aspect. Till I'm happy, I'll not leave my patient. I may have to increase my TBL, I have to increase my femur condyle, recut, do anything. But it has to be done well. At that moment, there's no regrets. I don't like any comebacks. कोई दिल में खलिश नहीं होनी चाहिए बाद में. एक मूवी में ऋतिक रोशन से किमी कैटरीना कैफ आती है मोटरसाइकिल पे और किस करके जाती है कि आई डिडंट वांट टू लिव विद अ रिग्रेट, सो आई डोंट वांट टू लिव विद अ रिग्रेट. And there's again a couple of videos just to show. I ask my patient to walk upstairs before discharging them from my hospital. They should be comfortably getting power, maybe assisted. They should go up and down the stairs. And that I attribute to the gradient curve. Because my patella is so balanced over the femoral condyle, it gets the maximum quadriceps power. The first lady is bilateral knee. The second is my schoolmate. She has been a professor of zoology in Bhubaneswar. She came all the way from there. In fact, I was schooled in Rourkela, that's in Odisha. So I did my 12th from there, and then I got selected in Cawnpore, a Bihari person having knowledge in Odia, Bengali, German, and came to Cawnpore to study. And this one is my batchmate. Only single knee is done. And I asked them not to use any physiotherapy. No physiotherapist visited her, even her home. And that the third video is after 3 weeks of her walk. So that is how a balanced knee is there. And the last video is again of my batchmate. She is a gynecologist. I showed that again. I have taken her consent. Many of my colleagues or my batchmates, even juniors will know. We studied together in Cawnpore Medical College. And that this is what she enjoys life. She dances. I know music is there. It will not go there, but I can tell you. So, this is what, when we do joint replacement, she is my batchmate, so she must be she may be 1 year junior to me in age. I feel I am young, I play every day, I do everything, so she is no less young. She has all the right to live a life of all the worldly matter. So, friends, joint replacement is a serious business, and try to do it as a one-time job. The first time is always the best time. Thank you.
My talk will give in the next session.